Thank you for joining us. My name is Paula Lomas. I am Senior Director of Clinical Communications here at the CF Foundation. And we know these are very unsettling times. There's a lot of anxiety in our community, and we're glad that you were able to join us today. We wanted to make sure that you know that we support you, and we know that you're dealing with a lot since you are the frontline care. And on Friday, we sent out the frequently asked questions link from our website. And people have asked, Paula, are you going to provide a handout? And the answer is no, because we have already updated those questions 3 times since Friday. So a handout doesn't seem to be appropriate at this time. And I encourage you to send that link to your families because they are asking questions, and we hope that you will be able to share those answers with them. We also hope that today's webinar will give you information so that you will be able to accurately and appropriately answer the questions that your families are asking, and that it will give you some guidance. So with that, I would like to turn to Dr. Bruce Marshall. He is Executive Vice President and Chief Medical Officer here at the CF Foundation, and he will be introducing our speaker.
Thank you, Paula. It's really an honor to introduce our featured speaker today, Lisa Saiman from Columbia University Medical Center. As I was preparing and reviewing the short bio that we included in the invitation, I realized that that doesn't do justice to Lisa's many contributions. So I'm going to take a couple minutes to embellish. As many of you know, Lisa chaired the IPC Guidelines Committee that published in 2013. She led a large and sometimes opinionated committee through the guidelines development process and delivered a high-quality manuscript on a complex and at times contentious topic. She easily could have exited stage left after that publication and left the implementation to us, but that's not Lisa. She contributed to the development of supporting educational materials, helped us respond to criticisms of some of the recommendations, and she visited many CF centers to meet with care teams and speak at family education days, all focused on implementation of the guidelines. So it was clear publication of the guidelines manuscript was not Lisa's goal. It was just a milestone in achieving her ultimate goal, which was to make a difference in the lives of people and families with CF. And that really tells you all you need to know about Lisa. But before turning the program over to her, I'll share a recent aha moment for me. Many of you know Dr. Tony Fauci. He's an iconic figure at the NIH who has advised, believe it or not, 6 presidents on various outbreaks, ranging from the HIV/AIDS outbreak all the way through to the current coronavirus. I saw Dr. Fauci do a very impressive interview on CNN a few days ago, and a light bulb went off for me. I realized that Lisa is the CF community's Tony Fauci. Just like Tony, she's always there when we need her. Just like Tony, she has an impressive command of the facts and puts them across in a very understandable way. Just like Tony, she calms anxieties and fears. And just like Tony, she instills confidence that we can overcome any challenge. So Lisa, we know you're extremely busy there at Columbia, and we thank you for spending some of your precious time with us today. So with that, I'll turn it to you, Lisa.
Okay, Bruce, I'm blushing from that introduction. Thank you so much for those kind words, and it is truly my pleasure to provide this informational update for COVID-19. And as Paul is reflecting, we're all really running in many, many different directions at once, and I hope I can make some sense of this for those of you that are participating in CF Care. So Paul, if you can please give me the next slide. So the outline of today's talk will be a timeline of where we are in this pandemic and update case counts, virology, including the nomenclature, the origins that we suspect of this virus and its genome and what we've learned, clinical presentations of COVID-19, prospects for antivirals and a vaccine, and we'll end with epidemiology and infection prevention and control that is informed by our understanding of COVID-19 transmission and containment and mitigation strategies. Next slide, please. So here's a timeline of the COVID-19 epidemic from December 8th to present. On December 8th, the first case was identified in China, although it is likely that it had been present in China for a while before that. People are estimating in November. On December 31st, China reported the cluster of cases of pneumonia to the WHO that were epidemiologically linked to a wet market that was located in Wuhan City, the Wuhan City seafood market. Those of you that may not have heard of the term wet market, what that refers to is a market that sells domesticated animals with wild animals that have frequently been captured illegally. So on December 7th, in real breakneck speed, a new virus was identified, and by January 12th, the whole genome was sequenced by Chinese investigators, shared with the WHO, and we had the first test kits available for diagnosis. On January 16th, the first case was identified outside of China, actually in Japan, and on January 30th, the WHO had a global alert entitled A Public Health Emergency of International Concern, basically alerting us to the probable pandemic potential of this virus, which was declared, along with the first death in the United States at the end of February. On March 9th, and these are obviously outdated, as Paula alluded to, globally there were over 113,000 cases that were confirmed and 4,000 deaths, for a case fatality rate of 3.5%. On March 10th, CDC reported 647 cases. That's more than doubled now. And the case fatality rate in the United States is similar to that observed globally, about 3.8%. I will emphasize that these early reports are dominated by individuals that sought health care and had medically attended events. So as we have a better understanding of the clinical presentations of COVID-19, including asymptomatic cases, we suspect very strongly that the case fatality rate will decline. Next slide, please. So here's an overview of the coronavirus and their nomenclature. So coronaviruses are an enveloped single-stranded RNA virus. There are 4 genera, alpha, beta, gamma, and delta, and they share properties with other single-stranded RNA viruses, such as hepatitis C, West Nile virus, Marburg virus, HIV, Ebola, dengue, and rhinoviruses. And why this is important, as I'll talk about a little bit more later, is that this gives us an opportunity to repurpose drugs that may have been developed for these other single-stranded RNA viruses. Those viruses cause respiratory, enteric, hepatic, and neurologic disease, and what's important to understand is that they're very common in other animals, non-human animals, such as camels, cattle, cats, birds, and bats, and of course us. And bats turn out to be a very important ecologic feature of the coronaviruses that have done species jump. So the novel 2019 coronavirus is the second coronaviridae that is known to infect humans. So we've known about 4 coronaviruses that we call the human coronaviruses that many of us can detect in our hospitals thanks to the multiplex PCR assays such as the BioFire respiratory panel. These are associated generally with mild respiratory disease, and it's estimated that they cause 10 to 30% of URIs, HKU1, NL63, OC43, and 229E. So again, those are the human coronaviruses. The more worrisome coronaviruses are those coronaviruses that are associated with severe disease. And we remember the SARS outbreak in the early 90s, the Middle Eastern respiratory syndrome, which is primarily present in the Arabian Peninsula. And now we have the virus that causes the problem we're dealing with now is called SARS-CoV-2, It has a lot of sequence homology with SARS-CoV-1, and the disease that it causes is called COVID-19. That was a very deliberate choice to remove any reference to Wuhan City and any bad associations that original title might carry. And what's important to recognize is that these viruses that make species jumps, we believe originated in bats, and in the case of SARS-CoV-1, again in a wet market, it's hypothesized that the civet cat was responsible, and people were slaughtering those cats and getting infected through that. And for MERS, it's generally thought to be camel, when people live intimately with their camels, groom them, and drink camel's milk. And we'll talk a little bit more in a moment about where we think SARS-CoV-2 originated. Next, please. So what have we learned thanks to sequencing the viral genome of people with COVID-19? So the figure in the upper right there is the virus isolated from the lower respiratory tracts of people who had COVID-19 and pneumonia that was sequenced and visualized by electron microscopy. We recognize, thanks to the conservation of the sequence, that this represents a single introduction into humans followed by substantial human-to-human spread. And there's very high sequence similarity in different patients, which is thought to represent very recent introduction into humans. And again, as I alluded to, this is a novel coronavirus with evidence of bat origin, and we currently believe that the intermediate host, although this could change as more information is available, is something called a pangolin. That's a picture of a pangolin. It is in the anteater species. It is highly valued for both its meat and its scales, which are thought to have medicinal properties, and it's one of the most heavily trafficked animal nearing extinction because of this wet market situation. So structural analysis and sequence homology between SARS-CoV-1 and 2 also have shown that they share the same cell entry receptor, angiotensin converting enzyme 2, which also may ultimately give us some more insight into potential therapies. Next slide, Paula. So what are the clinical presentations of COVID-19? So the mean incubation period is about 5 days, but it can be incredibly short, 2 days to about 14 days, although there are some case reports of even longer incubation, but really most cases are presenting within 14 days, and most cases even shorter, within a week. There's a very wide spectrum of illness. We're learning more about asymptomatic individuals who unfortunately are still capable of transmitting disease, albeit at a lower rate. Individuals with milder illness, and I'll talk more about that, severe disease requiring hospitalization, and some people who unfortunately die. Next slide, please. So the first paper that we had, and again, the publications are just coming so fast, were over 1,000 laboratory-confirmed cases of COVID-19 from over 500 hospitals in 30 provinces in China. The median age of these individuals was 47 years, and in most of the large series that have been reported, we still see this as a primarily adult disease, and we're not totally sure why children are spared. I'll spend a little bit more time on that in a moment. And also predominantly male. Again, this male predominance is not always seen, but seems to be noted in the majority of reports, and we're not sure if that has to do with behavioral characteristics or increased smoking among males, or things that we don't fully understand yet. The most common symptoms are fever, cough, shortness of breath, and diarrhea is less common, but it's important for you to realize that about 3 to 4% of individuals do have GI manifestations, and sometimes the GI manifestations actually precede the respiratory tract manifestations. The PCR, the RNA, has been detected in stools of infected individuals. So importantly, and not surprisingly to our audience, 15.7% of individuals had severe disease, and severe disease was associated with older age and comorbidities, including cardiac and pulmonary comorbidities and diabetes. About 6% of individuals required mechanical ventilation, 3.4% had ARDS, and that, of course, was associated sometimes with the need for ECMO. Unfortunately, in this publication, it was very difficult to sort out whether or not ECMO was well tolerated or had a benefit. Next slide, please. So these are the radiographic findings that are representative. The top panels represent non-severe, and the bottom panels represent a severe case. And of course, you can all appreciate the bilaterality, which is quite common. It's generally the most common description from X-rays and CTs has been bilateral opacities, ground glass opacities on CT findings. But it's remarkable that sometimes there are no radiographic findings, even in severe disease, and sometimes the radiographic findings are not present initially, and the patient progresses to develop radiographic findings. Most individuals that have severe disease, it manifests in the second week of symptom onset. So the original symptoms are relatively mild, and then the patient progresses. Next slide, please. So pediatric data is relatively scant. Today, CDC held its first webinar on OB cases and on pediatric cases, and generally speaking, there have been few pediatric cases reported in the literature. In the initial reports, children have only represented about 2% of cases. In a more recent report, that increased to about 13% of cases, but children seem to have milder disease. They seem to present more with URIs. It is uncommon to require the intensive care unit, although some children have had to be in intensive care units and ventilated. And of course, I alluded to the asymptomatic shedding. One of the questions that people have is, are children with asymptomatic shedding responsible for community transmission? But some of the epidemiologic looks in China, at least, have shown that most children are being infected from infected household contacts. So again, our understanding of this disease is really dramatically unfolding, so these early reports may be supplemented by data from different countries, including the United States. Children do have similar symptoms compared with adults: fever, cough, and malaise, and again, a minority do have GI symptoms. Unfortunately, we don't have data for children with comorbid conditions, and we certainly don't have data for children with CF. But the CDC and others are warning that comorbid conditions may put children as well as adults at an increased risk of more severe disease. As I alluded to earlier, there may be prolonged shedding. This is, of course, detected by PCR in both the respiratory tract and GI tract, and this may be when the person is completely well and recovered. And it seems to be, it's been described in very young children. Of course, because it's a PCR test and not actual viral culture, we don't know if this prolonged shedding is associated with transmission. Another question that we've been asked a lot is whether or not there's any evidence of transplacental transmission or any adverse effect directly of the virus on the developing fetus. And neither SARS nor MERS nor COVID-19 thus far have any evidence of transplacental transmission. And that would be either because of fetal demise or amniotic fluid or placenta. And we haven't seen evidence of virus in those settings. Miscarriages have occurred, as has preterm labor and preterm birth, but it's unclear if this is secondary to maternal illness and high fevers or respiratory distress, or directly an effect of COVID-19. The other question that's frequently asked is whether or not COVID-19 virus is detected in breast milk, and thus far it has not been, so CDC is saying that breastfeeding is safe. Next slide, please. So the case fatality rate, as I alluded to before, is probably higher, but we still are, this is unfolding since most of the cases are medically attended. So overall, in a much larger series than the initial series that I presented to you, the case fatality rate was 2.3% overall. And look, the sample size there was over 44,000 cases. But the mortality rate dramatically increases with age. So it's nearly 15% in people who are 80 years of age or older, 8% in people 70 to 79, and 49% in critical cases defined as respiratory failure, septic shock, and or multiple organ dysfunction or failure. It should be noted that in these early reports, no deaths were reported in children who were 9 years of age and younger, and only one death in people between 10 and 21 years of age. But again, mortality is increased in people with underlying conditions, so I'm sure that this will unfold as we have a better understanding of the spectrum of illness. Next, please. So this slide table is a comparison of some of the clinical features of COVID-19, the SARS and MERS, and I'll be brief here, but in general, although we talk a lot about fever, not everybody that has COVID-19 has fever, only 83 to 89%. So a prominent feature, but not universal. As I alluded to before, radiographic abnormalities are less frequent in COVID-19 than SARS and MERS. Mechanical ventilation was a very prominent feature of MERS, and the case fatality rate thus far for COVID-19 is markedly lower than SARS. SARS really looks like we controlled it. MERS still continues to appear in clusters. Next, please. So what about management? The keystone of management is supportive care and managing the complications for severe cases. It is felt, based on data from MERS and SARS, that we should be avoiding steroids in individuals with COVID-19, but I have not seen any published data for the risk associated with inhaled steroids. So an area that we have to think about, and is obviously very relevant for pediatric and adult pulmonologists who care for both CF and non-CF individuals. It's thought that steroids prolong viral replication. There are no current therapies with proven efficacy. There are studies underway. I'll highlight a few in a couple of minutes. And there are no current vaccines, but development is underway. And I'll just add that there are some platforms using the other coronaviruses, MERS and SARS, and a better understanding of what is thought to be protective immunity and the proteins responsible for that protective immunity. So there's a lot of activity for vaccine development now. So the next slide is really something very familiar to those of us in CF, and that is repurposing existing antiviral agents. So I'll be brief here and just give you a couple of areas of interest, and it's, again, a very, very rapidly expanding area. So next slide, please. Talks about existing antivirals that are including favipiravir. Favipiravir is a drug that has in vitro antiviral activity against SARS-CoV-2. There's an efficacy study right now in Japan looking at this agent in combination with interferon alpha. Ribavirin is a drug that we're very familiar with thanks to its miraculous activity against hepatitis C virus. There is some nominal activity against RSV. It was tested against SARS-CoV and MERS. Anemia is an unfortunate side effect of this agent, and we still don't know what the potency is. I think currently the most promising agent is remdesivir. This is a Gilead drug that's developed and tested for Ebola. There's a large safety database in over 500 individuals. It does have in vitro antiviral activity against SARS-CoV-2. It is a viral protein inhibitor that outcompetes one of the exonucleases. And there is a compassionate usage protocol that Gilead is running. They have not committed yet to making this compassionate usage protocol available to children or pregnant women, but they do have a hotline, and it is available. I know people in New York that have gotten it that way. And there are 2 clinical trials now that are an adaptive design that could use other antivirals if there's any activity, and I think this is really exciting and crucially important. And then on the next slide, there are exploiting RNA protease inhibitors. So there are approved HIV protease inhibitors, lopinavir and ritonavir, that are combined together. They have been evaluated for SARS and MERS. There is a non-randomized trial of this combination versus controls treated with ribavirin for the original SARS agent, and there was a lower risk of ARDS or death compared to ribavirin alone, but not a hugely robust response. And again, that disease went away, so we couldn't develop large-scale clinical trials. The question is whether or not it's effective against COVID-19, since there's so much homology with the original SARS-CoV virus. There is a phase 3 randomized open-label trial of lopinavir and ritonavir in people with mild COVID-19. Data from the original 52 patients versus 48 controls did not show that this combination was better than placebo, but again, I'll emphasize that was in individuals that had mild disease, so we'll see where that goes. So I just want to leave you with the the understanding that there's a lot of work ongoing now for repurposing agents with activity against other single-stranded RNA viruses for COVID-19 virus. Next slide, please. So what are the infection prevention and control strategies for COVID-19? And this schema here is very similar to other emerging infectious diseases, and that is identify, isolate, diagnose, and inform. So the identify part is a robust system of screening individuals for possible symptoms and evaluating them for epidemiologic risk factors. I'm sure all of you are getting a huge amount of information at your local institution, so I won't belabor that. The second part of this schema is isolating people to protect healthcare workers as well as other patients, and that is source control, source control, source control. So masking symptomatic individuals with just a plain surgical mask goes a hugely long way, and then immediately isolating these symptomatic individuals. And staff, of course, wearing appropriate personal protective equipment, PPE. Diagnosis for COVID-19 is first to rule out an alternative diagnosis. We have still a lot of influenza. We're still seeing RSV. We're starting to see parainfluenza. So ruling out alternative diagnosis when feasible. And then, of course, when you can, test for SARS-CoV-2. I'll talk about the problems we're having with testing in a moment. And then inform, and that would be your local informing strategies. Most places are informing their infection prevention control teams as well as their local health departments. Next, please. So another term that I'm sure you're all familiar with is the PUI, persons under investigation. And in the beginning of the COVID-19 outbreak, we were heavily relying on travel from Wuhan, from Hubei province, from China, and then from level 2, 3 risk countries such as Japan and South Korea, Iran, and Italy. But as community transmission is increasing, such as it's doing right now in Westchester County, New Rochelle, near where Columbia is, the travel history is becoming less and less relevant. So it's crucially important that you stay up to date with your local epidemiology. Also, another feature of this outbreak is that we're understanding this concept of proximate contact in large congregate settings that last for a while. So these would be settings such as weddings, bar mitzvahs, funerals, other areas like that. And the ongoing question is really trying to avoid these large congregate settings because now we're appreciating that some of these proximate contacts where people didn't really even remember prolonged face-to-face contact with the source case still related in infection, maybe through fomite transmission, through drinking glasses, through eating, through being close together for long periods of time. It's really unclear, but we really do need to avoid those congregate settings whenever possible. And we all understand how this could impact schools, which I know we're all thinking about on a daily basis. And I'm sure there are questions about schools that we'll be fielding in a moment. So another really important area for all of us is that we are now seeing in the United States more and more cases presenting to our healthcare facilities, and that is obviously in both ambulatory care settings, our emergency departments, and inpatient settings. So it requires an incredible increased index of suspicion for COVID-19 in people that have acute respiratory infections. And we have to be able to isolate these individuals appropriately because if they're not, then it puts us at risk. And if we are at risk and we get sick, then we are really adversely impacting our ability to care for all of our patients. So really crucial. And again, I'm sure you're getting huge amounts of information from your own institutions, and it's very, very important to try to stay up to date. As I mentioned before, we are strongly encouraged to test for other causes of respiratory illness, such as influenza. Next slide, please. So our understanding of transmission really informs our isolation precautions. And if anybody understands this well, it's the CF community. So we are all familiar with concepts of droplet and contact, thanks to all the work that we've been doing together about preventing patient-to-patient transmission in CF. So for COVID-19, we know that the most important route of transmission occurs through droplet transmission, usually during close exposure to the infected person. So the infectious droplets are produced during coughing or sneezing, and those droplets land in the mouth, the nose or the eyes of a susceptible individual. And so we need to protect our mouth, our nose, and our eyes. Hence, we wear masks and we have eye protection. And every institution is different in terms of the eye protection that they have available. Here we use a surgical mask that has attached to it a fluid shield mask. So our eyes, nose, and mouth are protected. But you may have other strategies. Less commonly, and I'll emphasize less commonly, COVID-19 may be inhaled. This is still not very well worked out and a theoretic possibility, and hence the need for airborne precautions. But CDC, WHO, and local health departments have moved away from universal airborne precautions for everybody with suspect or confirmed COVID-19. Instead, the airborne precautions are to be restricted to individuals who are undergoing aerosolized generating procedures. You'll see this now in the literature, AGP or therapies, and traditionally that would be things like intubation. BiPAP is actually an aerosol generating procedure, so people are rethinking the utility and risk of BiPAP, open suctioning, things like that. The other way that we believe that COVID-19 can be transmitted is through contaminated surfaces. There have been studies documenting that a person with COVID-19 in a room, when you go around and you do PCR on the surfaces in the room, you can detect the COVID-19 virus. So hence, what do? We perform hand hygiene and we don gowns and gloves. This is contact precaution, and this is intended, again, to protect us from getting contaminated by the virus. So that informs what we are supposed to do. Next, please. What about testing for SARS-CoV-2? I think you've all been watching the news, listening to your own institutional limitations. It's currently very, very limited in a lot of places. Many institutions, including our own, have limited testing capacity. It's fortunately expanding on a daily basis, and I really hope that's happening for all of you. So right now, and I can't speak to exactly what is going on in your individual institutions, but I hear about this through my colleagues and see this as recommendations by CDC and health departments, is to focus on patients requiring hospitalization because this informs the appropriate infection prevention and control, focusing on exposed symptomatic healthcare workers. Obviously, we don't want our healthcare workers to get sick, but if they're symptomatic and worked, that has implications for the patients they cared for and their colleagues. Currently, because we have limited testing capacity, there really is no reason to test the worried well. The ambulatory settings, we would love to test those individuals so we would have a much better understanding of the spectrum of illness. But currently, we don't have the capacity to do that. Soon we will, but we don't have the capacity. And again, I want to emphasize that people should not be referring patients who are well, that don't require urgent care, to the emergency rooms unless they need urgent care. We can't overload our emergency departments for people that are requesting testing. And obviously, it's crucial that we expand testing capacity because we're in a pandemic. Next slide, please. So when I was reflecting on the content for this talk, I realized how we were, as a CF community, in really, if I can use this phraseology, in excellent shape because of our sort of universal transmission precautions that we've been implementing now for well over 5 years. Patients perform hand hygiene and they wear masks. That's great. They're protecting themselves. They're preventing transmission in this context of source control, and if they, God forbid, had COVID-19, the hand hygiene is preventing them from contaminating environmental surfaces. We protect ourselves because we are performing hand hygiene and wearing gowns and gloves, and of course, if we suspect COVID-19, we're going to be donning masks and eye protection. We put patients in single rooms all the time when we close the door, so again, source containment. And we are familiar, if we have a patient that we think has flu, for example, of wearing the mask and fluid shields for droplet precautions. So this training and deep understanding of personal protective equipment is already a very prominent feature of CF care. Next, please. So I also was thinking about tips that I have learned and things I would say are considerations The first one being the need to conserve and secure personal protective equipment supplies. I am hearing reports of PPE being stolen from locked supply cabinets, from locked areas within hospitals by people who may be anxious, people who may be more nefarious. It is crucial that we secure our PPE supplies throughout the healthcare system for appropriate use. Another thing that I'm sure you're working on, and we are working on this, is how can we figure out strategies to reduce in-person visits? How can we do more phone consultation, more telehealth options? Again, to keep people away from the healthcare facilities, to protect them as well as to prevent us from becoming overloaded. It's crucial that you ensure your patients have masks to wear into the facilities, so that they're, because masks sometimes are hidden and they may be difficult to secure. So that is another tip. I'm sure we're all totally overloaded with information. So another suggestion that we've made here is to assign 1 to 2 team members from a division or from a service line to collate and disseminate the information that they're receiving from their local institution to help their colleagues. And another thing that we've been doing is we get these mass institutional emails that people sometimes don't pay attention to because they're coming from an unfamiliar sender. We are making the suggestion that these get potentially resent to the CF care team from the CF center director so that they'll be read and attended to. I also want to really acknowledge that this is a period of great stress for all of us, and suggest the potential for regular weekly COVID-19 discussions and check-ins. But another thing that I want you to really think about is the need to avoid close small group sessions. You know, as Bruce alluded to, I've seen how you will function. It's very typical to have a pre-clinic discussion when you're all in a room together. And one of the things that we've been talking about here is it would be a really bad thing if, for example, all the pediatric ID team were together in a conference room and somebody was sick and got everybody else infected. So this is a time when we have to really think about, this isn't business as usual, but alternative ways of communicating with one another. And again, I think the CF community has been way ahead because we've been doing so many virtual events and have a lot of capacity in this area. Also, I know we're all worrying about our own health and protecting our families, and you know, frequent hand hygiene is crucial for the avoidance of fomite transmission. Avoid touching your face. I've been watching myself in this little visual, and I'm like very aware that my hands are in my lap clasped together so I don't touch my face and sound like a hypocrite. Avoid congregate settings, and I can't emphasize this enough. You know, it really is important that we weigh each opportunity and just say, you know what, eventually this will be over and I'll be able to go back to my usual activities, but congregate settings are truly dangerous. Make sure you get rest, engage in self-care, and share tips that you learn for best practices with your colleagues. And again, I really want to emphasize, I know people are really scared, but the vast, vast majority of cases are mild and not severe. So next slide, I think, is my conclusion slide. So this current situation is evolving rapidly, and staying informed is key. As testing expands, cases will increase, but our understanding of the epidemiology, transmission, and spectrum of disease will increase, including our understanding of the impact on CF. And we all know that novel antiviral agents and vaccines are greatly needed, but they are currently being studied. So I think we're going to have many, many advances in that in the near future. So thank you so much for your attention. And I know now, Paula, we have time for questions and some answers.
Yes, thank you, Lisa. Thank you very much for that information. I'm going to go right to the questions, and our most popular question you sort of alluded to, but I want to discuss it a little further, really was about school and what, especially the pediatric care teams, what they should tell families. Should the families keep their children home from school? How should the care teams support that?
Yeah.
And what if there aren't even any cases in that community? Would that be different?
Yeah. So again, that's there's no right answer to this. We all know. It's a lot of schools have closed, and I want to just put out the thought that I'm worrying then when people say that there are no cases, it could represent lack of testing capacity. So I think we have to really reflect on that possibility. The other thing that is true is that a lot of schools have their own preparedness plans and are making decisions on a case-by-case basis for high-risk children. And based on our current knowledge, while there is no real clear guidance for CF, obviously, because there has been no clinical experience, people are saying that children with comorbid conditions are potentially at higher risk of severe disease. And so, it is really an understandable concern. And I think that each family and each care center has to weigh their concern for the risk of the child's condition. And I think it also should be weighed against whether or not how severe that child's illness is from the CF perspective, because it might be very different for a child with more severely afflicted lungs. And I also think that there should be a really active discussion about the opportunity for distance learning if a family is really feeling like they can't, it's just too much worry around this that it's not worth it. I think a lot of schools I'm hearing are starting to accommodate that. I also think that it's feasible that there'll be more direct recommendations coming from larger jurisdictions like the federal government about this, so stay tuned.
All right. Well, with that, then families want to know, what should they do about work? Potentially that they are, families ask, what if the parent or the guardian is a nurse or in healthcare, or perhaps even a flight attendant? Those were some of the frequent questions that we received. What do you think?
Yeah. So again, there has been, we are doing our very best in healthcare settings to prevent acquisition and transmission of COVID-19. But of course, it's not perfect, and we certainly saw that in other countries as well. It's crucial that this is, again, on a case-by-case basis. I think that healthcare providers are essential personnel. We have a responsibility to our patients, and that may be different than somebody that is in a different kind of work environment where there's an opportunity for working remotely at home. I think that the way that our mayor, for example, in New York City is really promoting that people think a lot creatively about opportunities to work remotely, and then within the workplace to avoid congregate settings and think about shifts that are different shifting. So there's no easy answer to any of this, Paula, but I think that as COVID-19 spreads more and more, I think that there will be a bigger emphasis on people staying home and working remotely whenever possible.
Let's shift gears a little bit and talk about the care team members. And you mentioned the healthcare worker. We did have a few questions about that in particular. What precautions should staff take, especially when doing PFTs and sputum cultures or throat cultures? Should we avoid doing PFTs on some patients?
So, one thing that I'm going to answer my question first and then answer that question, because one of the things that I didn't say during the talk that I need to say to everybody is do not come to work sick. Do not come to work sick. Somehow in healthcare, we have normalized coming to work. Oh, I just have a cold. Oh, it's just a mild flu. We cannot do that. COVID-19 can manifest as a runny nose and a sore throat, and you can be completely infectious. So it's really important that we give each other the support that we need, that if we call in and we say we're not feeling well, to be able to stay home and to work with your local workforce health and safety and infection prevention control about next steps, because every place is going to be a little bit different. So that is one thing that healthcare workers can absolutely do for themselves as well as for each other. As far as doing, with PFTs, I was thinking about this a lot, and you could argue also doing throat cultures, which we do for, of course, for a lot of our patients, is a cough-inducing procedure with the potential for exposing healthcare workers. And one of the things that there's no easy answer for this, but one of the things that we've been wondering about, and I know each care team is going to have to figure this out, is, what is the need to know versus nice to know test? And will we have an opportunity, the way I alluded to before, to potentially say, okay, during this crisis, maybe we'll reduce the frequency, again, assuming the patient is completely stable and with a lot of forethought. I think that for people that are doing pulmonary function tests, I think it would be crucial to speak with your local IPNC teams about the role of eye protection and wearing a mask, because again, that is considered a droplet producing procedure. And to date, most of the time, people are just wearing a gown and gloves.
From your talk, I think I know what the answer to this is, but I just want to make sure that I ask the question and you can give your answer. What advice do you give about routine clinic visits? So of course, when somebody's not sick, and would the risk of coming to the hospital outweigh the benefits of a quarterly visit? And I think I know the answer. Please give it.
I mean, this is like really not business as usual. I keep saying that, and I'm asking people to think creatively. This is not going to be with us forever. It will go away. And I can share again in the context of well-child visits. A lot of institutions are thinking through, okay, do we need to have a face-to-face well-child visit? Is it feasible that we could do a telehealth visit? And I think that, again, this has to be something that each care team should consider. How could they implement telehealth, and is there an appropriate role for telehealth, as you were saying, Paula, in the context of a clinically stable person?
And I would assume that that would be the same as, it would go the same for the non-urgent transplant referral visit. We do have some members of our transplant community on the line, and I think that it would be the same for them. Would you agree?
It's good that you brought that up, because another thing that I want people to think about, and they probably have, but let me just say it, is that if you are, you need to think through any group things that you do, like if you have pre-transplant evaluations where you bring together families, maybe a CF individual, non-CF individual in a group setting, you really have to rethink that. You should not be doing that. If you have people that you do like a walk through a unit to show them what it would be like a pre-transplant visit. I know some centers take the families through, okay, this is where you'll be hospitalized, et cetera, et cetera. You should be thinking about ways to do that virtually. These are all the things that we've been thinking through here. So again, I'm sure a lot of people are thinking similarly, but the sort of paradigm of what we're talking about is when it's feasible to do something virtually and you're not going to harm the patient, it's still going to be a safe approach for patient care, and I know that's a lot of ifs, we should be trying to do more and more virtually through telehealth and other mechanisms.
Since we talked about the lung transplant community, there was a question asking if we know the impact of this virus on the post-lung transplant community, and maybe based on experiences in other countries. Do you have any information?
Yeah, there's really no data that I could find. I think that people should just be watching for that, but I'm sure we could all imagine that transplant recipients are immunocompromised, and like any other infectious disease, they will be at risk for severe disease.
I think that things have changed in our country even since we received some of these questions, but I'll ask it anyway. They're really talking about travel. And is it okay, do you think, for people to, what's okay, what's not okay, I think is what people are really wondering, even if they travel to see family, in another state in a car, or, and they're asking their care centers, so I'm hoping you can give them some advice.
So again, this is very tough. I think that for healthcare providers, a lot of our universities have dramatically restricted our travel. Not allowed us to travel internationally, not allowed us to travel to meetings, most of which have been canceled now, of course, and even other forms of domestic travel, to really, really think through when it's air travel. I think there is probably a difference from going in your own car when you're not in an airplane for hours at a time. I think it's very important that people think through what they can delay, what they can put off. You know, I think that there are certain things like a death or a funeral that someone would just feel like they could not live with themselves if they didn't attend it. But in contrast, there might be other family events that could be put off until this is past us. And again, those events are congregate settings that have been associated with transmission of COVID-19. And I think we just have to make very, very individualized personal choices that, you know, really represent the best for our own health, the health of our families, and really the health of our patients.
Just wanted to ask a little more question though about work. I don't think we got too many questions from our adult care providers. And I think that they're trying to figure out how do they advise and counsel their adult patients who are working. And I'm assuming that what you would say, because I had a question in particular, like, what if they're a cashier? They're going to be, you know, a lot of people are going to be coming through their line. What do you think that that care team should say?
Yeah. So again, you know, it's really true, and you're saying it so well, that there are jobs that you cannot do remotely. You know, there are a lot of jobs that you can do remotely or you can do partially remotely, but a cashier can't work remotely. So, you know, the principles of all of this are, we know it's droplet transmission and we know it's contact. So it would be like if it was, this is one of the worst flu seasons that we've ever had. So the flu messages are still extremely good for COVID-19, which are frequent hand hygiene, don't touch your face, your nose, your eyes, your mouth. Yeah, depending on your tolerance, that might be a time where a CF individual might ask their boss that if it would be okay if they wore a mask because they're in such close contact with individuals. Typically speaking, for CF patients, we say within the healthcare setting, there may be front-facing CF patients that we might say to wear a mask. I think it's the literature is really not very supportive of wearing a mask to protect acquisition of COVID-19, and I'm sure you've seen those documents. But again, I think on a case-by-case basis, the most important thing is still frequent hand hygiene and avoiding touching the face. But you know, I can see how a person that was a cashier would be quite worried about their health for obvious reasons.
Right. Those were all the questions that we had received before this webinar. There are a lot of people that are that have some questions. I won't go to those now since that wasn't the agreement that we had with you.
Yeah, but I hope I leave the audience with the fact that there's no easy answers at all. There were never any easy answers in CF care, even when we were just doing regular infection prevention and control, to be honest. Now we have a really very complex situation, but I think it's important to recognize that this is going to end. This is definitely going to end. So when you're thinking through good guidance to people, if you can think through the concept of postponement or delay and where that is safe, I think that is a very, very important paradigm to help with CF care. So thanks a lot for the opportunity. I really appreciate it.
Thank you, Lisa. I think Bruce had a couple of closing comments.
Yeah, thanks, Paula. Lisa and Paula, thank you so much for such an informative webinar. I really enjoyed it and I learned some things. I'm sure everybody did. I wanted to close the webinar with a very brief message to the care center staff. And this has been mentioned before, I want to reinforce it. We realize these are difficult times and that can lead to stress and anxiety. We recognize that. We're here to support you. Please feel free to reach out. You know how to reach us. Paula, myself, anybody here at the foundation, we want to support you. Finally, we encourage you to remain focused on the safety and well-being of your patients and their families. Those are the people you serve. And also the safety and well-being of yourselves and your other team members that couldn't make this webinar. Very important. And then Lisa mentioned this, and I love these words. This is not business as usual. Don't worry about strictly following guideline recommendations or getting every data element entered into the registry, every visit. That's not important now. Take advantage of telehealth opportunities if they're there, or simple phone check-ins. Or there may be some patients doing so well, you can push out the contacts. You know better than us, but this is not business as usual. Do what you need to do. I assure you that your center grant will not be reduced for doing all the right things to protect the safety of your patients and their families. That's my assurance. So thank you all for joining us today, and we look forward to staying in touch with you.